Только тишина, да, никого нет.
Уже идет звук.
So hello students, we continue our lecture course, and now we should discuss the vascular topics about different vascular diseases. The most important is the limb ischemia. This situation occurs very often, and it's very important for us to have an opportunity to distinguish these diseases and to treat, of course. So, firstly, we need to differentiate the types of ischemia. It can be acute limb ischemia, less than 2 weeks from the onset of symptoms. It is a severe hyperperfusion of limb characterized by the following features: the pain, the pallor, pulselessness, poikilothymia, cold extremity, paresthesias, and paralysis. One of these categories of acute limb ischemia is assigned. So first is viable. Limb is not immediately threatened, no sensory loss, no muscle weakness, audible arterial and venous Doppler. Threatened, mild to moderate sensory or motor loss, inaudible arterial Doppler, audible venous Doppler, and it may be further divided into 2A, marginally threatened, or 2B, immediately threatened. And the third type or stage, would be better to say, it's irreversible acute limb ischemia. What does it mean? It is major tissue loss or permanent nerve damage, profound sensory loss, anesthetic, profound muscle weakness or paralysis, inaudible arterial and venous Doppler. So also we need to differentiate such a statement. So the critical limb ischemia. It is third and fourth stage of chronic ischemia after Fontaine calcification. It is a condition characterized by chronic, more than 2 weeks of ischemic rest pain, non-healing wound or ulcers, or gangrene in one or both legs attributable to objectively proven arterial occlusive disease. The diagnosis of critical limb ischemia is a constellation of both symptoms and signs. Arterial disease can be proved objectively with ankle brachial index, tracheobronchial index, and the tissue pressure of oxygen or skin perfusion pressure. Supplementary parameters such as absolute ankle and toe pressure and pulse volume recordings may also be used to assess for significant arterial occlusive disease. However, a very low ankle brachial index or toe brachial index does not necessarily mean the patient has critical limb ischemia. The term critical limb ischemia implies chronicity and is to be distinguished from acute limb ischemia. This is very important. The number of patients with diseases of lower limb arteries who already have critical ischemia reaches from 500 to 1,000 people per 1 million population per year. In diabetes mellitus, critical limb ischemia occurs about 5 times more often. 90% of lower limb amputations worldwide are performed indicated to critical ischemia. So this is the anatomy of the arterial supply to the lower limb. It's just to remember this material. It is well known. The anatomy is rather simple. In most of the cases, it is typical, but some variants exist. Okay, it's clear. So, to put the proper diagnosis, we need uh, to know which patients are at increased risk of peripheral arterial disease. It is a patient aged more than 65 years, aged from 50 to 64 years with risk factors of atherosclerosis. It means diabetes mellitus, history of smoking, hyperlipidemia, hypertension, or family history of peripheral arterial disease. So also there are patients that are aged before 50 years with diabetes mellitus and one additional risk factor for atherosclerosis. Individuals with non-atherosclerotic disease in another vascular bed, it means coronary artery, carotid, subclavian, renal, mesenteric artery. So the aortic aneurysm, abdominal aortic aneurysm is also included in the list of risk factors of peripheral arterial disease. Occlusive diseases of the arteries. So they are diseases conducing to gradual narrowing and complete occlusion of lumen of aorta and main arteries. Two basic diseases unite this term: obliterating atherosclerosis, obliterating endarteritis. Obliterating atherosclerosis. So it is a chronic disease characterized by lesion of arteries as local thickening in their wall of connective tissue with lipid infiltration of internal layer, conducing to stenosis of lumen of the arteries. Death rate from atherosclerosis is about 40%, and the number of amputation of the limbs is about 20% of the total number of patients with atherosclerosis. So it's very often. Most men suffer after the age of 60 years. So here you can see schematically the atherosclerotic plaque inside the vessel. So you can appreciate that the accumulation of the lipids is on the intima layer. Sometimes it will cause ulceration of the intima and formation of thrombosis. In this case, it will be called as atherothrombosis. It will cause acute limb ischemia. So this is atherosclerotic lesion.
А вы в какой вот? А вот, вы не перепутали?
Я нет.
Я тоже пришел во второй.
Да ничего. Да ради бога, не, ну вы же начали читать.
Here you can see the specimen of aorta with atherosclerotic plaques. Obliterating endarteritis. Obliterating endarteritis. It is a chronic inflammatory disease of the arteries with peripheral involvement of distal vessels of the upper and lower extremities and the subsequent spread of pathological process in the proximal area of the vascular system. Most men suffer under the age of 40 years. So this is the obliterating endarteritis, and this information is needed for put in the diagnosis, so differentiate between the atherosclerosis, for example, because patients with atherosclerosis they are mostly elder than 60 years. Okay, let's continue. So Leriche syndrome. Leriche syndrome is a form of peripheral artery disease involving the blockage of abdominal aorta and it transitions into the common iliac arteries. Claudication of the buttocks and thighs is characteristic for Leriche syndrome. Absent or decreased femoral pulse. Erectile dysfunction is also characteristic for Leriche syndrome. So this clinical picture we need to use to differentiate between simple atherosclerosis, or it would be better to say localize the place of occlusion. Okay, the differentially diagnostic signs for obliterating atherosclerosis and obliterating endarteritis. So the age we discussed it, 6. So for obliterating atherosclerosis it is male and endarteritis as well, also male. Disease course, obliterating atherosclerosis will have the gradual progression and the endarteritis undulating with the periods of remission and intensifying. Extremity lesion. Lower extremities, asymmetrical lesion in case of obliterating atherosclerosis, and in case of endarteritis, lower and upper extremities, and the lesion will be symmetrical. The nature of lesion for atherosclerosis affects the large arteries, elastic type of arteries, and for endarteritis it is medium range of arteries, muscle elastic type. The length of lesions, segmental and local for atherosclerosis and diffuse for endarteritis. Arteriography results, filling defect as a sign of plaque for atherosclerosis, and the contours of the artery evenly narrowed in case of endarteritis. So acute or chronic versus chronic occlusion for PAD. Acute, sudden onset, pain followed by paresthesia and then loss of function, usually due to an embolus, usually at sites of vessel bifurcation. In case of thrombus, clot is already present in a diseased vessel. I explained earlier that it can be ulceration of intima, and over this ulceration forms the clot. For chronic occlusion, gradual onset will be actual. It will be long-standing symptoms of intermittent claudication in atheromatous vessels which were previously present. A collateral circulation will have been present in this case, in case of chronic occlusion, because our organism tries to compensate the ischemia, and the time period is, in some cases, it will be enough to new vessels opened, anastomosis opened, and so on. And this is, you see the arterial thrombus in coronary artery. You see how big is it, and it almost narrows the lumen of the artery. Risk factors for peripheral arterial disease. The same as for atherosclerosis. So diabetes mellitus, chronic smokers, hyperlipidemia, family history. Obesity also predisposes to atherosclerosis. So features of peripheral arterial disease. The common presenting symptoms is intermittent claudication. What is it? It is the most important symptom for for peripheral artery disease. What is it? It is a fatigue, discomfort, cramping, or pain of vascular origin in the muscles of the lower extremities that is consistently induced by exercise and consistently relieved by rest within about 10 minutes. So the patient walks, and then this pain make him to stop. So this is called the intermittent claudication. Very important sign. What else? It can be paresthesia, it can be rest pain, it is a late symptom, and almost in all the cases it is. Tells us about the critical limb ischemia. Gangrene and ulceration, it is a late symptom of PAD, and tissue loss. Minor tissue loss, it is non-healing ulcer. Focal gangrene with diffuse pedal ischemia, and major, extending above transmetatarsal level. Functional foot is no longer salvageable in such a case. Features of acute occlusion. They include the pain, the pallor, paresthesia, numbness, paralysis or weakness, subfascial edema, distal and later proximal contracture. So this information is very important. On examination, what can you find? Is decreased or absent peripheral pulse, arterial bruits, decreased skin temperature, atrophy of extremity, dystrophic nails, hairless skin, ulceration, gangrene. On physical examination, the weakening or absence of pulsation on the arteries can be measured. Systolic sound auscultation of aorta and the arteries. So normally, what arteries we should on what arteries we should determine the pulse. The first one is the femoral artery. The first one is the femoral artery, just below the. Okay, it would be better to see it in inguinal crease to feel it. Yeah, we press it to the bone and feel the pulse. In most of the cases, of course, excluding the Lirish syndrome, the pulse will be present on femoral artery. Then the popliteal one here for determination of this symptom, the leg is placed in correct position. We need to use both hands and try to press the popliteal, sub-knee artery to the knee joint, back space. Then the arteria tibialis posterior tibial artery, and dorsal pedis artery. will be in first interbone space on the foot. So the ankle brachial index (ABI) measures the ratio of lower to upper extremity blood pressure. It is a significant predictor of cardiac events. Who should have an ABI measurement in clinical practice? It is a patient with clinical suspicion for lead, lower extremity artery disease, lower extremities pulse abolition or arterial bruit, typical intermittent claudication or symptoms suggestive for lead, non-healing lower extremity wound. Also, the patient at risk of lead because of the following clinical condition: atherosclerotic disease, coronary artery disease, and peripheral artery disease. Other conditions: abdominal aortic aneurysm, chronic kidney disease, heart failure. Also, asymptomatic individuals clinically free but at risk of lead. It is men and women aged higher than 65. Men and women aged below 65 classified at high CV risk according to the European Society of Cardiology guidelines. Men and women aged higher than 50 years with family history of lower extremity arterial disease. How to measure ABI? The patient should be in supine position with cuff placed just above the ankle, avoiding wound zones. After a 5 to 10 minutes rest, the blood pressure is measured by a Doppler probe on the posterior and anterior tibial or dorsal pedis arteries of each foot and on the brachial artery of each arm. Automated blood pressure cuffs are mostly not valid to ankle pressure and may display overestimated results in case of low ankle pressure. The ABI of each leg is calculated by dividing the highest ankle systolic blood pressure by the highest arm systolic blood pressure. Claudication distance, an indication of severity in many classifications, in those which are used in Russia, those which are used in Europe, in the United States, and mostly we can tell it all over the world. Fontaine stage classification of peripheral arterial occlusive disease. Stage 1, asymptomatic, PAOD, decreased pulse, ABI less than 0.9, distance more than 100 meters, so 1 kilometer is a rather big distance. Stage 2, intermittent claudication, ABI is about 0.7 to 0.9, distance is about from 200 to 1000 meters. Stage 3, daily rest pain, blood pressure less than 50. And stage 4, focal tissue necrosis. Grading claudication. Initial claudication distance, it is a distance patient first experiences exertional pain, and absolute claudication distance, it is the furthest distance patient is able to walk. It is important to differentiate. Most patients are asymptomatic, detected either by the low ABI or pulse abolition. Among these, a subset may have severe disease without symptoms, which can be related to their incapacity to walk enough to reveal symptoms, heart failure, for example, and reduced pain sensitivity, which takes place in diabetic neuropathy. A typical presentation is an elderly patient with several comorbidities who present with toe necrosis after a trivial wound. Okay, here you can see the tissue loss, small. It is the ischemic ulcer. It is the mixed gangrene. We cannot say these these parts are in dry gangrene. And this is a dry gangrene. So probably it is diabetes. And here we can see the beginning of the wet gangrene, which is the worst outcome. Here you can see the erythema, which is characteristic of critical limb ischemia, such a color of discoloration of the skin and an edema, light edema. Experts from European countries came to conclusion that it is appropriate to combine patients with third and fourth degree of ischemia in one group, which they defined as patients with critical ischemia. The selection of this patient is necessary because they have high risk of amputation. To avoid this, they need systemic hospital treatment with preventive aim. Instrumental diagnostic that we should use to diagnose completely, to put a proper diagnosis of disease and to choose the proper approach to treat. So what do we need? We need the Dopplerography, we need CT angiography, magnetic resonance angiography, and simple conventional angiography. Dopplerography. It must be combined with ABI management, ankle brachial index. It presents about 45 to 90% of sensitivity and more than 95% of specificity to detect stenosis, more than 50%. So, and if we will even see the stenosis more than 50%, in most of the cases it is hemodynamically not important, or hemodynamically significant stenosis of the vertebral artery we see here on the picture. So here it is, the stenosis, here is stenosis, and this is one. So what else? Angiography and MRI. On the left picture you see the arterial thrombosis of aorta, arterial thrombosis. And the right side you see the CT angiography. Sensitivity and specificity of CT angiography to detect aorta-iliac stenosis is more than 50%, where 96% and 98% respectively, with similar sensitivity about 97% and specificity 94% for the femoropopliteal region. The very important method of investigation. It is invasive, but it's less invasive than the angiography. Yeah, and it gives us it depends on the specialist, of course, it depends on the quality of the machine and CT thermometer. This is very important, but this method is applied very often nowadays. So the angiography. At the place of introduction of the contrast agent can be injected directly in the test vessel and in the mostly used, injected into the arterial system to obtain venous and parenchymal phase of contrast enhancement of the organ. By way of introduction of a contrast agent, it can be puncture, the injection directly through the needle puncture, and cathside, the introduction of catheter, overall semi-selective and selective. So here you can see the angiography. This is femoral artery. So, and it is absent. We see only the collateral arteries. We see only the collateral arteries. Only the collateral arteries. Here you can see the external iliac artery nerve. So, Leriche syndrome. This is the coronarography and the stenosis formation in the coronary arteries, which can cause infarction. This is the Takayasu disease, the narrowing of the aortic arc vessels, typical for young women. What is it? It is a form of large vessel granulomatous vasculitis with a massive intimal fibrosis and vascular narrowing, most commonly affecting the young or middle-aged women in Asian descent. Though anyone can be affected, it mainly affects the aorta and its branches, as well as the pulmonary arteries. Females are about 8 to 9 times more likely to be affected than males. Principles of treatment. So, risk factors modification, exercise program, antiplatelet agents, reopolyglucin, aspirin, clopidogrel, metabolic therapy, actavigen, selcasiril, vasopressin, alprastrel, surgical revascularization techniques, bypass methods, and in some cases amputation. So also we need to talk about treatment of claudication. You say it's just a symptom. Yes, it is, but it is the most important symptom of chronic ischemia. So, to do exercises or not, it is a question. To do or not, if the exercises cause pain, why should we do them? We don't like pain. Of course, no one likes. But for producing the factors of neoangiogenesis, so formation of new vessels, formation of anastomosis, we need to give the physical exertion for such patients. It can be 30 to 45-minute session, 3 or more times per week, at least 12 weeks it should pass. The value of unsupervised exercise programs is not well established. Cilostazol 100 milligrams twice daily. It can improve symptoms and increase walking distance, indicated for lifestyle limiting claudication. Contraindicated in patients with the heart failure. Pentoxifylline 400 milligrams 3 times a day daily. Consider as an alternative to cilostazol. effectiveness of pentoxifylline is marginal and not well established. So, if you will treat such a patient, you need silestazole. It is much better than the pentoxifylline. Pentoxifylline is rather old drug, rather old, and its effectiveness, it has the effectiveness for the period of time when you inject such a drug. When you finish the injections, the course of injection, all the symptoms will quickly come back. Okay, so this is the European Society of Cardiology guidelines. What to do with claudication. So if we see the claudication, we need to assess the risk factors and medication. Control of risk factors: smoking, hypertension, dyslipidemia, diabetes, antiplatelet and lipid-lowering therapy, initiation of exercise therapy, preferably supervised. So after that, claudication impairs significantly daily life after exercise therapy. What should we do? If the patient can be operated on, so we need to make an additional investigation, aorta iliac, assessment of lower limb arteries. We need to assess aorta iliac region, common femoral artery, also isolated iliac lesions not extending down to common femoral artery, occlusion of the aorta distal to the renal arteries down to iliac level. So if we have the femoropopliteal lesions, we need to if it is stenotic occlusive lesions less than 25 centimeters without prior endovascular procedures, then we will do, or we will try to do, endovascular procedure. If the stenotic or occlusive region is more than 25 centimeters, or it is reocclusion of superficial femoral artery, in such case we will do an open surgery. It depends on what we will use, autograft or maybe some artificial graft. If we will see the common femoral artery lesion, we need to apply the hybrid therapy in case of associated superficial femoral popliteal stenosis. In case of isolated iliac lesions not extending down to common femoral artery, we will do the endovascular procedure. So we will continue with the chronic limb-threatening ischemia, limb-threatening ischemia. How to treat? Firstly, pain control, risk factor management, wound care, antibiotics, if needed, drainage of septic food, if needed. Patient is a candidate for revascularization. If no, then amputation. If the patient is not a candidate for amputation, then we do the urgent imaging and we decide if revascularization is feasible. It can be stenotic lesions or long occlusions. If it is stenotic lesions, we do endovascular first, If it is long occlusions, we do take the greater saphenous vein so if no great saphenous vein is available, then firstly endovascular first. If it is successful revascularization, then simple treatment of the patient. If it doesn't work, or we know that it will not work, then we will do reduce surgery or endovascular treatment. If it is impossible, then amputation mandatory. In our country, we will treat using the bypass grafts, not just the endovascular procedures. No. Open surgeries still exist nowadays. Okay, acute limb ischemia. For make a classification, we need the Rutherford classification. There are three main categories. First one is the viable limb, no immediately threatened, sensory loss is no, muscle weakness known, arterial and venous Doppler signal is audible. Threatened, marginally threatened, salvageable if promptly to treat, if we try to make a prognosis. Minimal to less or none, inaudible, audible. If it is B category according to Rutherford classification, the salvageable food will be salvageable in case of immediate revascularization. Findings: the more than toes will be affected and associated rest pain. Muscle weakness mild and moderate, and the same as in Doppler signal, the same is with the second type of Rutherford classification for acute limb ischemia. So, the irreversible acute limb ischemia, description and prognosis. The major tissue loss or permanent nerve damage. Inevitable. Profound and anesthetic foot, profound paralysis, and inaudible arterial and venous pulse. What to do with acute limb ischemia? First, heparin and pain management. If the limb is viable, no neurological deficit, Rutherford 1, then initial workup, it will be digital subtraction ultrasound, duplex ultrasound, and CTA, computed tomography. Revascularization within hours, thrombolysis, thrombectomy, bypass. So, if the limb is viable with neurological deficit, it is Rutherford 2, then we need to urgently revascularize such a patient to do thrombectomy and bypass. So, if in case of Rutherford 2, then we do the urgent revascularization, thrombectomy, and bypass. If the vascular lesion is present, then endovascular therapy and surgery, and if it is absent, then the medical therapy and follow-up. If it is irreversible acute limb ischemia, then only amputation exists. PT buttocks, only amputation. Okay, take a look on these recommendations, what to do in such a case. So if you can mention the approach is rather aggressive, rather active. Okay, let's continue. What else can we do? What else can we do? We can do the sympathectomy. Thoracoscopic sympathectomy, for example, in patients with Raynaud syndrome or Raynaud disease. Or it can be lumbar sympathectomy. Here you can see the clip at the ganglion's upper end, and lumbar ganglion, lymphatic vessel, and psoas muscle, just for orientation, and inferior vena cava. So according to this anatomy, we understand that this is the right lumbar sympathectomy. So when can it be done? In case of endarteritis and Raynaud syndrome, when we have the prolonged narrowing of the vessels, which are muscle elastic type of vessels. If it is only elastic, for example, the aortic aneurysm, so it will be no effect from such an operation. So sympathectomy, not bad results. It shows it is minimally invasive. It is rather simple. If you will see all the anatomy and you will meticulously follow the surgical technique and sparring the anatomy. So it is good operation and rather nice. Okay. So the reconstructive surgery. What can it be? Reconstructive surgery. It is endarterectomy with a patch plastic. For example, it is shown here, where we can see the narrowing of the vessel, and we do endarterectomy. We remove the endothelial layer with the atherosclerotic plaque, and it is important. In former years, they performed just suturing of the artery. Nowadays, in such a incision, we should put the plaque. To prevent the narrowing of the vessels by our sutures. So, the endarterectomy with a patch plastic can be open, semi-closed, and closed. Here you can see the plaque sewed up to the artery. Okay. For reconstruction, we can use the vascular grafts, autovenous. It is the best if it is possible to apply. Yeah, we use the great saphenous vein, external uvular vein, and synthetic implants, porous, corrugated, cardboard, braided clothes, and knit. So revascularization for femoropopliteal disease. The femoropopliteal bypass surgery, the primary patency at 5 years is about 60 to 80%. So most of the patients are patent. Yeah, the grafts are patent. Autologous vein preferred to systemic grafts. Synthetic grafts, I'm sorry. Perioperative mortality is about 0 to 3%. And femoropopliteal angioplasty, the patency at 2 to 5 years ranges between 40 to 70%. Technical problem due to several anatomic issues: occlusions via stenosis, diffuse disease, adductor canal, disease in run of the vessels. Perioperative mortality is very low. Okay, revascularization for aorta-iliac arterial disease. So aorta femoral bypass. The cause for this is the Leriche syndrome. Primary patency at 5 years is about 81–85%. So perioperative mortality is about 5 to 8%, reserved for severe diffuse disease cases. Percutaneous intervention. Patency at 5 years is about 65–80%. Perioperative mortality is about 0.1%. It is a treatment of choice. What else can we do? Arterialization of the venous bed, rare variant of surgery. It is the arterialization of the great saphenous vein according to the method in situ. So you can see that we sew up the tibial artery to the vein, or popliteal artery to the vein, and it will be the arterialization of the or oxygenation of the veins. Okay, it can be used in some cases where nothing else we can do, no good operation we can do, then this is the only way. Okay, endovascular revascularization for claudication. It includes the balloon dilation, it is called angioplasty, stents, and atherectomy. These techniques continue to evolve and now include the covered stents, drug-eluting stents, cut-in balloons, and drug-coated balloons. Revascularization is performed on lesions that are deemed to be hemodynamically significant, and stenosis selected for endovascular treatment should have a reasonable likelihood of limited perfusion to distal limb. Stenosis of 50 to 75% diameter by angiography may not be hemodynamically significant, and resting of provoked intravascular pressure measurements may be used to determine whether the lesions are significant. So here you can see the different variants of intravascular surgery. So the cryoplasty, so covered stent insertion, Nitelon stent, the front runner XP, which will remove the plaque, thrombectomy using different balloons, subintimal re-entry, so formation of new vessels from inside of their wall. Yeah, especially it can be done in case of thrombosis of aorta. It is an operation of choice. Okay, amputation. Well, the properly performed amputation can be life-saving for the patient. It may often be a better therapeutic alternative than an ill-conceived, futile attempt at vascular reconstruction doomed to fail for lack of adequate recipient vessels. Major goals of amputation surgery: preservation of the functional length, durable coverage, preservation of useful sensation, preservation of symptomatic neuromas, prevention of adjacent joint contractures, controlled short-term morbidity, early prosthetic fitting when applicable, and early patient rehabilitation. So currently there are no consistent criteria that can be applied before surgery. The main objective of amputation is removal of sufficient disease, infected and gangrenous tissue to permit the stump to heal but at the same time retain adequate limb length for prosthetic fitting. The use of scoring system dependent on the preoperative angiogram to assess the runoff vessel situation provides a practicable and direct way to help predict the level of amputation in an ischemic lower extremity. However, it is not totally reliable and should be used as one of the factors to be considered when an amputation is required. Other invasive and non-invasive techniques can also be utilized in assessment of circulation, in determining amputation level preoperatively. Assessment during the operation of local circulation is of extreme importance. Why it is so? Why it is so? Because we can make an amputation, we can think firstly about the functional result. We can think about the patency of the prosthesis after the operation. How useful will it be? And we will try to make as long stump as possible. So generally for surgeons, for those who perform amputations, it is such a statement exists. As long stump will be, as more functional will it be. So this is very important. And of course, if to follow just the functional result, we can cut just small part of the leg and do not assess the blood supply during the operation and before surgery. And after the operation, we will receive the insufficiency of the stump. It will not be able to heal up. So here you can see the stumps, the different forms: clavate, cylindrical, conical, normal, conical, pathologically conical. This is D, pathologically conical. Why it is so? Because this is the bone. The bone was not cut and the amount of soft tissue was not enough to cover the bone completely. Of course, this stump will not work, and if we will apply the prosthesis, here we will receive the ulcer, and the patient will suffer from ulcer disease, and maybe in future it will be the inflammation with the pus formation, and we will again perform the amputation. Okay, here you can see the normal stump, the most often operation which is done in case of lead. In most of the cases, if not to apply some additional methods of investigation, I mean visualization of the vessels, this is the most reliable level of amputation. Such a stump will heal up in almost 100% of cases. This is why it's oftenly performed, especially in those countries that are not equipped with enough equipment for blood supply determination, where the prosthetic plants do not work enough. So this is the method of choice. Okay, thanks for attention. next Monday. We'll see you at the same time. Okay, good luck. See you together. See you next Monday. If any questions, you can just print in our discussion. I will try to answer your question. Okay. Okay, guys. If no questions, then we will finish our lecture. Thanks for attention. Good luck.